Hello and welcome to today's Health IT Analytics webcast sponsored by BigBear.ai, predicting success for operational change in hospitals. I am Vanessa Palmer-Desiato, Project Manager at Xtelligent Healthcare Media and host of today's webcast. First, I'd like to thank our sponsor, BigBear.ai. As a leader in the use of artificial intelligence and machine learning, BigBear.ai makes AI-powered decision support accessible and scalable for any organization. Through its solutions and operational expertise, BigBear.ai helps customers crystallize and accelerate operational decision-making to gain business agility and competitive advantage. Today's presentation will be a discussion with our speakers and conclude with a question and answer segment. Audience members can submit questions at any time during the webcast using the question tool to the left of the screen. For all technical matters or difficulties, click the help icon at the bottom of the screen. A recording of this webcast will be made available following this presentation. With that, I would like to introduce our speakers for today's discussion. Jean Day, Data Science Manager, Clinical Analytics at Seattle Children's Hospital and Affiliate Assistant Professor of Industrial and Systems Engineering at the University of Washington. Holly Schmidt, Director of Throughput Operations at Ann and Robert H. Lurie Children's Hospital of Chicago. And our moderator, Kurt E. Champagne, Senior Vice President, Healthcare Solutions at ProModel, a BigBear.ai company. Kurt, I'll now hand the floor to you.
Thank you very much. First of all, I'd like to welcome everybody to our webinar today. We really appreciate the attendance and we're really looking forward to a fruitful conversation. So the reason for meeting today is that streamlining and improving hospital operations has never been more critical than it is today. With nursing shortages and unforeseen surges due to the triple-demic, we're bursting at the seams once again. Data scientists and process improvement professionals need reliable, trustworthy tools to ensure the highest standard of care for the patients. What we're going to do today is learn how 2 hospitals have successfully implemented these kinds of solutions and data in predictive analytics. The panel discussion is going to focus on data-driven decisions, change management, and lessons learned, while hopefully we walk away learning how predictive analytics can help bottom line, improve hospital stress levels, how you can lead change management and drive performance improvement, and how you can fix the right now. So in preparation for this, we've prepared a lot of questions, but we're just going to go through probably 10 or 15 of them. So I'm going to start off by having our panelists tell us, can you tell us about your journey in using predictive analytics as part of process improvement? And if you could, share an example. Gene?
Hi, thanks. My journey in using predictive analytics for process improvement, I mean, it began with my doctoral work way back when I was doing some research for the 375th Medical Group at the Scott Air Force Base, where we were modeling both their emergency department and their internal medicine clinic using discrete event simulation in order to make operational improvements, and continued through my time at the Veterans Administration in St. Louis, Missouri. There, the first major piece of process improvement that we did using predictive analytics, and I specialize in discrete event simulation modeling. That's sort of the predictive analytics tool that I have used personally, rather than sort of newer methods in machine learning. But we wanted to model the arrival and bed rooming process in our emergency department at the Veterans Administration, and we wanted to model what would happen if we put a provider at triage so that we could disposition certain lower acuity patients from triage. And so I modeled the system, and we were in fact able to improve our throughput by about 16% without adding any FTE or any exam room space or additional resources. So that was a very exciting project. And I have continued to do that work throughout the rest of my career at the Children's Hospital of Philadelphia and now here in Seattle.
Excellent. Thank you. Holly?
Thanks, Kurt. I actually started clinically. So I moved from a clinical role in which I was in the acute care space and ICU space in the hospital. And I moved then into a quality and improvement role. And from there, my brain continued to look at ways to do things better. I was doing it in the clinical space constantly. I didn't realize quite how much I was doing that. But really, as I moved into the space and did a lot of benchmarking, networking, found the additional role of looking at exactly what Jane's doing discrete event simulation and how to do that, because we were finding that we were pushing teams to pilot more and try new and change frequently. And when we then started to do some simulation, we did add the role here at Lurie Children's. We used the role to prove the role, prove concept of the role, and we're able to hire in. And the early simulation of that was you looking at the OR, and we have 2 floors that we simulate patients on, or we see patients on for the OR. And the idea came from Frontline, and they were ready to go live with their pilot. And we came in and did a simulation, and it completely, essentially pulled out the rug from what they were planning to do and led them to the right answer. So they saved an incredible amount of time and effort and disparity when it wasn't working and ready to walk away, that we were able to get them to the best solution first. So that really, I mean, I was sold from that moment on. That was just really how you look at the two together and the pair of that. So it's been powerful since.
Excellent. Thank you. And you're the perfect straight person for my next question. So how can data solutions better inform operational performance? And can you compare and contrast kind of the old way to the new way using data in simulation or process simulation? Holly?
I sure can, Kurt. So the first thing that we did is validate data, because we found that people did not believe the data. So the very first thing we did for better data solutions was to begin by validating all of the data. So once we started to do that, then we built that into dashboards, and we use Epic as a system here as an EHR. So we then are using dashboards to help give us more live feed, live data. We then use, because we have now validated data, we can build simulation based on that. We can then use that in daily performance metrics to make decisions daily, operationally, on what's happening and what we're doing. We have huddle boards that we, again, have oversight, and we use lean methodology to look at these huddle boards and make these decisions, and again, make rapid decisions differently. The difference from what was done earlier, that's such a good question, because I came from a space of more data is better. And that is, very much an academic facility, and we need more and more and more because we're doing research, and we might need to know that. And that was a really early lesson taught to me by the data analytics group, was measure what you need, period. You don't need everything. If you're not going to measure it, do not gather it, and don't get stuck in analysis paralysis. So figure out your metrics early. So that was definitely the difference in kind of the old way and then the new way, and being able to take these tools and take this data and make decisions faster, and then simulate something that you're going to then implement much faster than you would have previously.
Excellent. Thank you. Gene, same question.
Thank you. I'm gonna piggyback off of, I think, a lot of what Holly said, but I think that, we talk about being and wanting to be data-driven institutions for decision-making, but data by itself doesn't drive anything. It's just a big pile of numbers, right? In order to understand what the data is telling you, you need people who can process the data into information. But even information isn't enough, right? You may know what's happening, but that doesn't give you instructions in what to do next, right? So the next sort of layer in the pyramid of being a data-driven organization is using information to create evidence, and then using evidence to create direction. And that's, I think, the real key is data by itself doesn't help you make good decisions unless you have people who understand how to interpret the data, and then how you can validate that the decisions you're making with it are good ones through appropriate metric tracking. And so, I think one of the great insights that Holly just shared is essentially understanding, using these predictive analytics to understand what not to do, right? Because there's often no more powerful direction to take as an organization than to stop and say, thank goodness we know not to do that. Because one of the great hidden costs in any healthcare organization is quality and performance improvement projects that don't work. And so isolating good predictive analytics provides an evidence base and direction to isolate your performance improvement and quality improvement initiatives to those candidate interventions which are likeliest to succeed.
Excellent. Yeah. So it makes me want to skip down to a different question because of the input you've just given us. So, what works well in convincing executive leadership on the power of predictive analytics? Now that we know it can be useful and it needs to be well formed and pointed at the right target, how do you use it then to help convince executive leadership? Gene?
I would say, if I can start, my career has been built on bootstrapping success. You start with pilots in small, isolated environments. Frequently, that means working, and small is not the right word necessarily, but in environments that are sort of self-contained, like the emergency department, right? The emergency department is a hospital within the hospital. And it has all the same services and needs, but it's on a much smaller scale than a whole, 350, 400 bed hospital is. And so when you can convince leadership to let you do a pilot study of the EDO, of like an emergency department or another small area, cardiac center is often another good hospital within the hospital, that allows you to generate successes which then snowball, because nothing is more powerful than demonstrating success, right? And so you start in an environment where there's less risk of failure in a financial sense, because you're not taking on an enormous, like, enterprise-wide project, and you demonstrate that you can predict, that you, first of all, that you can model and validate your simulation or your model of your environment, then that you can project the effects of interventions, process interventions, into the environment, and then that when you adopt those interventions, that your prediction comes true. And when you do that on a small scale, leadership is almost invariably willing to engage it on a larger scale. And the people that live within the system are also willing to engage it, because health professionals like nothing better than improving the way that we deliver health, right? That's our mission. And so when you can demonstrate that success, that's how you get people to buy in.
Holly, same question.
Jean laid it up very nicely for me. It definitely is small, limited scope, iterative. Like, you want to just keep piloting, and you pick an area. You absolutely find an area. And to be quite honest, people want to come along with you. When you demonstrate success and you demonstrate that there's been an improvement and a change, people want to do that themselves. And Jean is exactly right. That is what we're here to do. We're here to make things better. That is what our passion is. That's why we went into healthcare. We want to make things better for the patient. So as you look at this and you go to leadership, of course, there are tough conversations, and it's hard to sell at times when you look at this big change. But again, when you start small, go deep, and you really make an impact in an area, and then people will start to come along the train, and it makes a huge difference. As you continue to show success, people love to come along.
And I think the last thing I will say also is, it really helps to be embedded and to have a shared commitment to the outcome and to demonstrate expertise, right? Once again, the best predictive analytics engine in the world is not going to be useful without real human beings in the environment who can implement the solutions and do the change management, right? And so, when you have that shared commitment to the outcome within an institution, I think there's a lot more credibility associated with that. And the best AI in the world still requires the credibility of the people that are there to implement it. And so, when a consultant comes in and says, I have a magic black box that's going to tell you how to magically fix your organization, I think executives are rightly skeptical. Instead, you need people who can be embedded within the system, act as champions, act as local subject matter experts, both with hospital level data and with advanced predictive analytics tools, who are committed to the mission from within rather than just serving as itinerant consultants.
Sure, sure. So I'm sure many people are thinking now, so how does an organization get started? What are kind of the first steps? Holly?
Good question. When we did this, when we started to look at this, you look for leaders that are engaged. You look for those change agents that are interested in doing something different and trying something different, and are really experts at leading people and leading the change management aspect of people. So without being able to follow along in the change aspect of this, again, going back to what Jean just said as well, you need people. We need frontline, we need the engagement. So as we have a leader that's engaged, that's the area I would start. And then as you start looking at what are the problems within that system, this is where my PI brain, my PI hat goes on, and I look at like doing a Kaizen within the area. How do we identify the areas? Where do we want to start first? As we Pareto out the issues, then you can start to divide and conquer what's going to happen. I mean, there are obviously some just do it's. There are things that you can then model and tie. You need to get your data in place. The data is also the key to this. You need to, if you don't have clean, clear data, you can't see where you're going. So you need people, you need an engaged leader, and you need clean, clear data to know where you're going. So that's how we started it. And then you want to show success early. So some of the things, as you look at the people and they're giving you ideas, you want to go change that today. You don't want to wait for a week or 2 weeks or 2 months. You told me that printer's broken. Great, I'll get it fixed for you today, because that starts to build trust. And then that trust helps you to continue as you humbly ask them questions, as you humbly get their input. That guides where you're going next. The front line has all the answers. We just need to ask them respectfully.
Sure. Quick wins always win out.
Mm-hmm.
Jean, anything there?
I think Holly's dead on right. It requires engaged leaders. It requires engaged frontline people. It requires leaders who are simultaneously visionary in the sense that they are willing to embrace new technologies to make improvements that are capable of generating insights that we did not used to have the capability to generate. But it also requires leaders who are humble enough to accept the innovation coming from below, right? And to allow analytics teams to say, when we operate in your environment, when we look at the hospital as it is, here are the tools that we believe that we can build that are going to drive improvement, right? And allowing that bottom-up approach to building the products and processes that are actually going to make significant change along the way. And then the leaders can act as champions for those products that we produce.
So kind of piggybacking on something that Holly said a moment ago about change management. So once you've done the work and you know that you have a solution that'll work within your hospital, how do you kind of help effectively lead change management? And because it was you, Holly, that brought it up, I'll go to you first this time again.
Yeah, absolutely. So this is actually one of my favorite spaces, because if you engage frontline at the beginning, it's their idea. So they are the ones that help you to create the change. So obviously, and we use Cotter's change model as we look at this. And as you think of the urgency, that's the reason that you start and you sat at the table to begin with. What's the urgency behind this? What's the why? And then as you move through, I like to then empower again frontline to help that change happen. Because it's not because Holly says it or Jean says it or Kurt says it. It's because of the urgency behind it and helping them to understand how that will impact their day to day. The goal is to make things more efficient. It's to do the right thing and to make things more efficient and to move smoothly. It's not to add things for them. So it's, as we think of the change model in that, it's helping to coach then some of the frontline providers and leaders to be able to do that and take that out to the front line.
Gene?
Yeah, I mean, of course, change management is its entire own discipline, right? And so every hospital that I have ever worked in has a team of performance improvement consultants that are highly trained in change management and can support the adoption of new business processes and new clinical processes. And so as an analytics team, I really support building bridges between the analytics team and the performance improvement team to make sure that they are leveraging the data that the analytics can provide, and to make sure that analytics doesn't expect, as we often do in analytics, that just providing good information is going to naturally result in change, which is, kind of magical thinking on the part of a lot of the analytics side sometimes. And so, building that bridge, as Holly said, if good model building, whether you're talking about discrete event simulation or AI models or old-fashioned tabletop modeling games for the emergency department, et cetera, those work best when the entire model building process is collaborative with the people that live in the system, right? I am perfectly capable of building a model of a system and querying the model and trying to come up with improvements. But almost invariably, the improvements, for the best ideas for improvement, come from people who already work in the system. And then that also engages them and validates their own ideas and work. Sometimes because you can say, wow, you came up with a great idea, let's do it. And sometimes you can say, this idea that you've had for a long time, when we model it, doesn't actually provide the results that we thought it was going to. And even that is a kind of closure. We all know people who get stuck on, if only we did it this way. Well, now we can test that and we can say, we wish that would have worked, but we don't think it's going to. And that can provide that closure that allows them to sort of step back and re-engage with different kinds of processes. And so, change management in a hospital is, in any organization, any complex organization, is a psychological process as much as it's a business process, right? It's about getting people all on the same page, believing in the data, believing in the information, believing in the evidence, and then moving forward with the direction. And that can be done through collaborative model building and through the idea generation on the frontline provider side. I think of myself as a person who builds tools that test hypotheses, right? We can test whether or not your ideas are going to work. And if they do, we can provide evidence to leadership that they should be implemented.
Excellent. So what are your tricks for effective communication while implementing a new process? Like if you're trying to maybe get wins for analytics, for example, how do you get that kind of spread through the organization? Gene, sorry.
How do we get it? What are the tricks and how do we get the spread? I don't think that there are tricks per se. There's no, this one weird trick that's going to solve your hospital's implementation problem. So the way that we organize our current analytics teams is with delivery teams that have subject areas. I lead the team that does, for example, inpatient analytics, inpatient flow analytics. We have an advisory panel that includes, some senior vice presidents, but also managers and leaders in the organization, in our command center. And they act as champions to disseminate the tools that we build. They help us refine and iteratively improve the tools that we build to make them more and more useful to them. They provide us with new and interesting questions. They help us prioritize our tasks. And so, when you have that direct line to both leadership and the frontline users and adopters of your tools, that provides that two-way feedback, right? Analytics is not a here's the information, go fix your problems situation. It's a collaborative build between professionals on both sides and leaders on both sides who can encourage the adoption and act as champions for what you do.
Excellent. Holly?
I have been very fortunate to have a very strong leader around me. And one of the best practices that I continue to see her do, as well as some of the other leaders, is the positive accolades for teams. So it goes back to a very basic premise of positive reinforcement and letting people know what you're doing. And it's really powerful, and acknowledging the work and letting people know and doing it in different forums. There's some of the simulation work and some of the work that our DES employee did was then brought up at the big 100+ person meeting, and I specifically called out his name because he should be recognized in addition to the front line, in addition to the other groups that I was recognizing. But I think it's so incredibly important to communicate those positive experiences. There are negative. There will always be negative. We will always find something that didn't work. But I think acknowledging and communicating what worked encourages people to do it again. The other piece that I have found incredibly powerful is when people give me ideas, I write them down and I remember who gave me the idea, and I go back to that person and tell them what happened with that idea. And what happens is they come to me with more and more ideas, which is awesome and overwhelming. But quite honestly, when they see that their little idea that was heard changed, they will come to you with other little ideas that you can change as well. So, and other much bigger ones. So
Yeah, that's excellent. I mean, both those points seem simple, but they're so completely necessary. No one wants to just work for a paycheck. They want to work to improve their hospital and the whole situation for the patient. So excellent. So I want to ask now, what have been the pain points along your separate journeys to process improvement? What are your lessons learned? Holly?
I learned pretty early to be humble and to ask questions, and that you're learning every day. So failure is actually succeeding at the next project. You learn how to fail, and you learn how to humbly fail, and it's okay, because you can't be right with every single estimate. You can be more right with predictive tools, I will tell you that, but it's really valuable to be humble and to get the front line. I think another pain point that I had is acknowledging that the lack of standard work, and across many organizations, the lack of consistency has been an incredible pain point. It's now at the top of my list of the conversations. And probably, gosh, I could go with many pain points because this is improvement. So there's a lot of things you learn along the way. But I think last is that there's never an end. And when I realized that this is never complete, it helped me to continue to show that, it's not just a project that I close the book and walk away. This is ongoing improvement, and we get it to a nice place. But when you walk away, you're walking away. You're not looking at what else is happening, and you're not paying attention. You can't improve anything else. So that was a huge pain point for me. Was, in patient care, the patient would get discharged, or I would complete my care. That I would not need to see the patient anymore, and it was complete, but not really, because the next patient came along and some of the same problems were happening again with that patient. So it's continuous improvement. So I think once I realized that, it was helpful for me to see it was okay to not have an end and to still continue to improve.
Gene, what were your pain points along your journey?
I've had a lot. I think there's a couple that are sort of generally good lessons though. That are, one is, um, don't it's okay if your sacred cows get slaughtered, right? Like, if the big project that you really believe in isn't going to be adopted, if the executives aren't behind it, that's okay, right? Have the humility to understand that executives always have more information than you do, right? And even if what you know is, what you're looking at and your project in your environment, if you know this is the right thing to do, you're still not looking at the whole picture, and there's information that you don't have. And executives have more information than you have. They're not going to share everything. They can't. And so sometimes decisions get made that um, that are not necessarily the ones that I would recommend, and that's okay. Similarly, there are times when there are projects which I have believed should not go forward and that were really not going to work, and were going to cost the organization a lot of money. And I said that, and they went forward with them anyway. And I was right. And you know what? That's okay too. I don't need to, people don't always have to listen to me, right? Like, even if I feel like I have really good information, one of the big pain points in any professional career is to have the humility to understand that people are going to make their own decisions, especially when they're in leadership. And all I can do is give them the best advice that I know how to give, given the information that I have. And so sometimes things have gone wrong and haven't worked, and sometimes I've been right, and sometimes I've been wrong. But I've always been trying to give the best advice that I can give based on the analysis that I can conduct.
Yeah, it makes me think of another question. We've all been part of implementing these kinds of solutions here on this panel, but one of the hardest things I found is, how do you educate your leadership and the consumers of your work that are always want to deal in certainties when dealing with uncertainty, probabilities, the things that come with analytics? How do you share or get them on board with just the idea of it and why it's so powerful? Gene?
So humans in general are really, really bad at understanding uncertainty. Um, I read somewhere once that humans really only understand 5 probabilities. They understand 50-50, they understand 99% chance, 100% chance, 1% chance, and 0% chance. That basically we know if something is really unlikely but possible, or almost certain but not guaranteed, versus it's a coin flip, right? But in the real world, there are many, many more probabilities than that, infinitely many. And taking leadership on the journey of understanding uncertainty and error bars and likelihoods is always going to be challenging. And that's why I include uncertainty estimates in every analysis that I do. Additionally, I always try to translate that uncertainty into easy to use, um, common examples. So, for example, if I think that, if my analysis says our census is going to be above a certain threshold 80% of the time, instead of saying 80% of the time, I'm going to say 4 days a week, because that gives my leadership a much better sort of concrete example of, okay, 1 day a week we're going to have a challenge with staffing if we operate to this analysis. Whereas if we change our threshold, maybe it's 2 days a week, maybe it's a day a month, et cetera, et cetera. But I always try to translate it into those easier to understand, more familiar environments so that people can get their head around them easily. Because just saying 80%, nobody really has a sense of what 80% means from a gut instinct perspective.
Holly?
We do something similar around here. So I appreciate Gene's comment about that. We've also tried to align it to color. So, a stoplight is a very familiar look and feel. And we've tried to align that to color with a certain group, understanding what those colors mean. That can um, the leaders, leadership will change kind of what they're looking at or why they're looking at it, but you want to try to align as much as you can. And it is complicated. It is complicated to understand, when you come from a statistician perspective versus, or you're putting on that hat compared to, well, what does this really mean? What does 80% really mean? To Jean's example, like 80% of what? So I think, colors have been also helpful to us with definitions clearly behind it, but then the core group following those definitions and knowing those definitions that they can explain it as things change.
Very cool. Yeah. I'm going to start taking some of the questions that are coming in from the attendees to the meeting. So let me start off by asking a question from Ben Brody. He was hoping to hear about this, how predictive analytics helps the bottom line and helps reduce hospital stress levels. I think I ended with Holly, so we'll start with Holly here.
This is an ongoing question, and it is incredibly important. I think a question from the sense of continuing to show the value in it. And I think you can look at it from the angle of time spent in traditional methodology. So as we look at traditional PI and the amount of time and hours, and if you look at the hourly rate of some of those meetings, if you combine that in traditional methodology versus the combination of some of those meetings with the predictive tools and those decision making, I think there's definitely some key ROI in there. I think, which also helps bottom line. That's one way to look at it. There are many. I know Gene has some other ones that I'll let him go into. I think specifically then looking at hospital stress levels, I think it's incredibly important. Currently we have a model that we run at noon every day in the ED that gives us the prediction of the full day census. I think there are clearly other opportunities to look further out, to intersect and use more AI with that. Specifically in the ED, it shifts around school schedules, it shifts around weather, it shifts around a storm, it continues to shift. So I think that's really helpful and then can help set up those that, and it's what are we going to do with it? So that's great that the tool tells us that, but now how are we going to operationalize that and what decisions are we going to make when this happens? When we see that we're going to have a day of X amount of patients, who do we, is that when we call in extra staff? Is that when we shift nursing resources? Is that when we, so I think that piece of it is incredibly helpful. And then looking at, in that example, patients that are leaving the ED without being seen. So there's a risk factor there that's significant, can be significant. And there's also the bottom line of patients that you're not treating, that you could be treating. And if you had the tool, if you combine the tool to be able to do that, there's ROI within that.
Excellent. Gene?
Yeah, I mean, I think everything Holly said is exactly right. I think there's a few additional ways that you can think about it. So first of all, for example, we went from being reactive in our flow to what the hospital census and staffing currently was, to making our decisions based on our predictions of where the hospital is going to be in 12 and 24 hours. Now, that definitely took a lot of change management to bring everybody on that, to trust the prediction of where we were going to be. But once we did, first of all, I mean, in terms of just straight bottom line, yeah, we eliminated more than 1,500 hours of huddles every year with senior leadership, right? Those are very expensive meetings. We have incredible qualitative feedback from our shift administrators about how much easier the job is now than it used to be. That has to have translations into, it's pale green ROI, if you will, because it's very difficult to calculate an actual dollar figure. But when that has translations into things like reduced staff turnover and training, there's an enormous amount of return on investment. And then the other way that I would think about it also is in the strategic decision making. So, for example, every hospital is constantly making capital investments in staff, in facilities, in equipment. And when you use these predictive analytics to identify the ROI of potential ideas, you can essentially calculate the return on investment of one idea versus the return on investment of your opportunity cost of the next best option. And you can essentially prove this is the most lucrative way to invest the X million dollars of capital investment we're planning on investing this year. And so, we see that all the time in strategic analysis when, we're trying to decide, should we open up a new unit that's for maybe ED borders, or should we invest that money in an additional CT scanner or two, and the FTE that it takes to establish it? Those are decisions and trade-offs that without predictive analytics and analysis are extraordinarily difficult to predict. But I can take those questions and I can say, if you do A, this is what your ED throughput's going to be. If you do B, this is what your ED throughput's going to be. And you can run a quick calculation and you can say A is worth $12 million and B is worth $14 million. And both of them serve the community need in ways that are of critical value. And therefore, we believe that B is the better option to take. And you can make those decisions, again, data to information, to evidence, to direction.
Excellent. Thank you. Thank you very much. So another question came from Hassan Yusuf, and it was, do you engage, we've talked about engaging other people, clinical and leadership, but do you engage doctors and advisors before the analysis is completed? And we'll start with Gene.
Yes, absolutely. We, like, when I say clinical partners, I literally mean we work with physicians directly. We work with charge nurses and frontline providers. I work with residents. I work with med students. I like to think that my role as a systems engineer and a data scientist in healthcare is to assist in providing the most transparent environment possible so that a physician or a nurse has the direct information that they need in order to most rapidly and effectively nourish their relationship with the patient so that they can practice medicine while I'm practicing technology, right? That's my role. And so it is an extraordinarily intimate partnership with the clinical staff.
Holly?
We can't do it without them.
Mm-hmm.
You have to have them at the table. They need to be there. It's critical to the success and the outcome of the project. It's frontline engagement, and that frontline is a physician, a provider, it's the EVS housekeeper, it's the phlebotomist, it's lab, it's whatever the project is that you're doing. You have to engage the people doing the work, and it's all steps of the work. It's not just the manager in the unit, that you're trying to change that has quote unquote time that they're supposed to spend on that. It's the people doing the work, and it might not be every meeting that they're at, but you get their engagement, you get the information, and specifically about their role. And I use the provider specifically. It's incredibly helpful to me to validate the data that I'm looking at. There's observations that are important just to sit and be a fly on the wall and watch and validate time and numbers and what's happening and understand the process. But then there's also what comes out of your EHR. And if we're going to look at doing predictions off of this, well, if we're not measuring the right number, it's not going to give us the right outcome that we're looking for. So absolutely physician engagement, but I would say that for all of frontline, it's incredibly important.
Yeah, it's excellent. I always use this analogy, although it's a really unfortunate healthcare analogy. Whenever you're going to do something like this, like a project for process improvement using simulation or whatever kind of analytics, you always need to get all the fingerprints on the knife before you start carving. And if you think about it, when you can't end a project and have it be I, it has to be we. And you don't get to the we unless you get all the fingerprints on the knife. And I think you guys have described that beautifully. Okay, another question from Ben Brody. How best can you keep your EHR data extract in sync with your offline reporting tools or even your simulation tools? And for this one, we'll go to Gene first. It's always a challenge.
So I definitely want to stress that I am not an EHR specialist.
Right.
So I work with teams that help us do this. For some tools, we build extracts. Like we built a data lake that has our census data that comes from Epic every 15 minutes in order to make sure that we have low latency data there. A lot of the Epic data that we have comes on a daily extract from the dump to the data warehouse overnight. Definitely, there are challenges with data latency and maintaining those things, but the in some places analytics is part of IT, in some places it's part of performance improvement. I think the real key is making sure that just like you need to have a close partnership between analytics and clinical staff, you need to have that IT, that core EHR staff as part of the team as well. Because if you look at the way that data moves through an organization like this, it's a circle, right? Physicians and nurses enter the data into the electronic medical record. The electronic medical record digests it. It does ETL processes, extract, transform, load processes into the data warehouse. Analytics pulls it back out of the data warehouse to build dashboards to provide information and direction back to the clinicians who then make those decisions. And so your data is constantly spiraling throughout the organization, which means that you need, as team members, persons who are capable at every step of that data process, from entry to transformation to digestion to display.
Holly, same question. Keeping your data in
Thanks,
line.
Kurt.
Yep.
Thanks, Kurt. I think it's really, I agree with Gene. I'm not an EHR specialist, so I cannot speak to that. But I can tell you many problems and issues when people are looking at old data and they're not updating the data. And again, it depends on your organization. It depends what is feeding it. Is it data that you can look at that is okay to look at from yesterday, or do you need a live feed? Do you need to know what happened an hour ago, or is it okay to know a static number of patients that arrived for the day? And it depends on the operational decision or the clinical decision you're trying to make with that data. So if you're using an AI component and looking clinically, then you need up to the second data being fed into the system. So it's challenging. It doesn't, unfortunately, Ben, I don't have a perfect solution for that other than working with your group, your organization, because it's something that's ongoing. I think there's definitely an awareness. It's something that I literally saw here in a meeting earlier today, was a data extract from another system and comparing it, and it gets confusing. And then we want one source of truth. So I think the big piece of all of that is to get the, what is it that you want to do with that data, what decisions do you want to make? And is it okay that it's a day old? Is it okay that it's a week old? I don't know that we make a lot of decisions from a quarter of data, an entire quarter combined versus what happened an hour ago is much more lively. So such a good question. And I wish I knew the way to solve it for everyone.
Yeah. And it's a difficult question, always has been, and all the work I've done. I think Gene and you both said you need a strong relationship with IT. Epic has solutions like Reporting Workbench, where there can be an automated data dump that comes out of their solution. I know there's a similar one for other electronic medical records. Or you just have a real data guru that has got a stored procedure query that feeds your model or feeds your analytic solution. But it definitely requires that IT fingerprint on the knife, for sure. Okay. Well, I'm going to be very cognizant of time. It's 3:56. I'm going to ask one last question, and that is, describe the good and bad sides of predictive analytics. And since you come from such different backgrounds, kind of how it's affected your career. And we'll start with Holly.
It's gosh, I don't have a lot of negative to say, so I'm gonna try to find some bad. But I think that it is such a powerful tool when used in combination with people. I think the good is you need people. You need, I love, Kurt, your hands on the knife or fingerprints on the knife. You need fingerprints on the knife to use the tool. So it can be incredibly helpful. It helps to feel good about the decisions that you're making. I think that it validates what you're already thinking. I think for some of our clinical staff, it's validating. It takes some of the cognitive load off of what they're trying to do with everything else happening in healthcare. So I think that's been incredibly helpful. The bad, not enough of it, probably is what I would say. I would like more of it. So I don't. Maybe Jean has some more bad, but that's probably what I have right now.
Gene?
I do. So here's what I will say is the bad side of predictive analytics. Far too many people think that predictive analytics gives unbiased solutions and answers. They think that because it's math-based, that it can't have issues around equity. That nothing is further from the truth. Not only will algorithms reflect the biases of the people that write them, whether those are conscious or unconscious, but they can also inject new biases that nobody ever thought of. For example, the great example of automatic faucets that did not reflect off of darker skin tones, and so African Americans and East Asians often couldn't use automated faucets because the algorithmic eye didn't detect their skin. You can inject problems using predictive analytics if you are not careful, if you don't validate them well, if you don't test them well, if you don't think about it. That's why at Seattle Children's Hospital, for example, we have implemented a data ethics screening process for every data product and process that we do. And that was published in the Journal of the American Medical Informatics Association. If I can give a plug to our work there, you can check out the data ethics checklist. So do not think that just because you are using a so-called objective algorithmic process that you are not injecting additional biases. Use the power of predictive analytics to detect those biases and then act on them.
Thank you very much. I'd like to take this last couple of seconds to thank our very talented panelists and all the attendees that came here today to watch. Please don't let this be the end if you don't want it to be. Reach out, get in contact with us if there's more questions, or even you have an opportunity or want to talk in person. We're more than happy to do this. And we really appreciate your time. Jean, Holly, thank you very much.
Thank you, Kurt.
Thanks so much, Kurt.
Wonderful. Thank you all. That concludes today's Health IT Analytics presentation. Special thanks to our speakers, Jean, Holly, and Kurt, our audience, and our sponsor, BigBear.ai. Thank you all, and goodbye.